Okay, class. In this unit, we'll be discussing ventilation or how we assess ventilation. Remembering back from our physiology lecture that respiration and ventilation are separate things, all under the umbrella of breathing, right? And when we're looking at respiratory rate and some of the things we can observe from a visual inspection, we're really primarily looking at ventilation. And again, if you're unsure of the difference between that, go back to the normal pulmonary physiology lectures. So the first thing that we're going to do when we're assessing someone's breathing is we're going to do a quick observation, right? The first thing is just your initial visual inspection or even auditory inspection, but you're just going to look at them, right? Are they in distress, right? Are they gasping for air? Are they short of breath? Are they somnolent, right? Which means like they're kind of out of it, they're drowsy. Is their breathing noisy or wheezy? Do you hear not visible wheezes, audible wheezes, right? That can give you a pretty good indication of whether someone's stable or not, or maybe there's some sort of impairment with their breathing. And as we get into your cardiopulmonary courses, your chest examination, you'll learn more about this and how we would follow it up with auscultation of different lung segments. But we can gain a lot just from looking at a patient and kind of hearing their breathing in a certain sense. Next, we'll look at their body position or posture, right? Are they sitting quietly, comfortably, upright? They have a barrel chest, which is linked, we see that with a few different conditions you'll learn about later, COPD. Are they slouched over? Are they guarding something? Guarding means like supporting your ribs. If you've ever had an injury to a rib, right? You had that pain as you breathe in. You often see patients doing that if that has happened to them to kind of brace themselves, reduce the pain. Do they have pes excavatum or pes carneatum? So the sunken chest or projections from the sternum. So abnormalities in the osseous formation of the sternum. And then what's their breathing pattern, right? And this can get a little bit vague and nebulous when people start breaking this down. But really the concept of this, we're looking at the rate and the depth of breathing. That is what a breathing pattern is. So are they breathing too fast, right? And we'll get into what that means in a bit. Are they breathing very shallow breaths? So they're not taking full normal breaths, or are their breaths excessively large? Like are they heaving basically? And then looking at the amount of accessory muscle use, and I specify this because as we learn in our pulmonary physiology lecture, right, your accessory muscles, quote unquote, are always active during breathing, and they're necessary for the movement of the upper chest wall during inspiration. But in times of distress or in times when we need, we need to draw in more volume for whatever reason, those muscles will become more active and they'll be noticeable. So these are your scalenes, your sternocleidomastoids, even your pec minor. You'll see those maybe even hypertrophied in someone who has a chronic issue, like in COPD. But that's, again, another clue, right? Are they having to use other muscles to get even more volume in? That's typically not a normal thing. Do we have asymmetrical or even paradoxical chest wall movement? So asymmetrical would be maybe a difference between right and left, right? One side doesn't expand as normally as the other side. That could be due to a rib fracture. That could be due to a pneumothorax, potentially. Is it paradoxical? So normally when you breathe in, your chest wall and your abdomen move in the same direction. They move outwards, right? That's normal, right? So you have that belly rise as the chest rises. That's normal because your abdominal contents get compressed from your diaphragm that descends and it pushes, right? And I'll do a quick little diagram here, but we'll do a rough schematic of your chest. With some ribs. There you go. You got your diaphragm here. And you get your abdominal contents. We'll draw a little stomach. And then your abs. So as your diaphragm contracts down, right, it pushes all this stuff, and you have a rise of the belly. And again, of course, as we expand the chest wall, right, our chest should move out in this direction too. So the abdomen and the thoracic chest wall should move in the same direction as we breathe in. Again, abdomen rises because of the compression of the abdominal contents. It should expand out a little bit, and your chest wall should move out a little bit as volume increases in the thoracic cavity. That's normal. Now, there are some populations where those movements are paradoxical. You can see that in patients with spinal cord injuries, TBIs, post-stroke, where that would be an abnormality, right? So you'd have, the chest wall rising, but the abdomen is sinking in, or vice versa. The abdomen is, rising while the chest wall is, sinking in. That's not normal. So we can glean that just from looking at a patient. The other thing is too, like, what's their pulse oximetry? You'll learn more about that. Are they using supplementation? Are they on RA or room air, which we refer to often in the note? What's their delivery method? You'll learn more about that in your cardiopulmonary coursework. But again, these are things that we can gather even before like doing an actual physical exam, assessing breathing rate, or pulse oximetry. We can just look at the patient and get a pretty good idea. Are they just breathing comfortably, or is there some sort of issue here? And remember, right, going back to this pattern, notion, everyone's breathing is going to be a little bit different, right? There's a spectrum of normal movement in breathing as well. And if someone's like not reporting acute distress and like they're not breathing, they're not tachypnic, or they're not, breathing really, really, really low, or bradypnea, that's not, super concerning. Everyone's breathing is going to be a little bit different. And even this, like, the amount of movement between the chest wall and the abdomen, it's going to be different for each person. It just should move in the same direction. That's a key thing to stress. I think a lot of people get too dialed in this, where it's kind of inconsequential and not super important. But again, there are some obvious, situations where it would be a concern. So respiratory rate. The way we assess respiratory rate is looking at the rise and fall of the chest. So, a full rise and fall of the chest equals 1 cycle, right? So when we're assessing respiratory rate, we want to look at, for both rise and fall, that counts as 1. So the normal guidelines are going to be different depending on your age. So for an adult, normal respiratory rate, or you might see this referred to as ventilatory rate, because again, respiration and ventilation are a little bit different. For an adult is 12 to 20 breaths per minute. And again, give or take maybe 1 or 2 breaths, just because some people, tend to breathe a little bit more, slower or more relaxed than others. Again, you factor this in with symptoms and other issues, but that's the acceptable range for an adult. Now, an infant, or really anyone who's younger, their breathing rate is going to be a little bit faster. So really until you get to about adolescence, where the rib cage is now more matured, breathing rate is going to be markedly faster, right? So an infant, about 30 to 60, if you've ever held a baby, basically like it almost feels like they're vibrating because they breathe so much faster. It's because their rib cage is almost horizontal and it's cartilaginous. So they don't have as much movement, they don't have as much volume, so they have to move a lot more breaths per cycle to get the same amount of volume that we would get in from 1 normal breath. So it's not too uncommon. And it's interesting if you go back to, we'll cover this with heart rate too. If you look at when like running gait and stuff starts to normalize, breathing rate gets closer to an adult's around age 6. It's about 18 to 30. And that's kind of when your normal running gait kind of develops as well too, Nikkei, which is just kind of fascinating how these things kind of co-develop. Now, the way we assess respiratory rate, there's a couple different ways. There's a hand-on shoulder technique, which you got to be mindful of, just because like everyone's personal boundaries is going to be a little bit different. So always ask for permission. But that's an easy way to gather it, because you can feel the rise and the fall of the chest, and you can just count the number of rises and falls within a interval of time. We recommend at least 30 seconds or a full minute if someone has labored breathing or is in some sort of respiratory distress. But for most people, we can do this in 30 seconds. There's also just a visualization approach. Now, visualization, again, you're just gonna be looking at the shoulder or the chest wall and looking for them rising and falling. Now, again, you got to be mindful of this, because you don't want to be just looking at someone's chest, right? Like that could kind of be inappropriate. So just be mindful of that. Now, the thing that we want to make sure that we try to avoid, which is what makes this a little bit challenging, is we don't really want patients to know that we're assessing their breathing because they're going to change their pattern of breathing or adjust it, right? It's all Hawthorne effect. So what we often do is when we're assessing pulse rate with the radial artery pulse, we'll tell patients that we're assessing it for a minute. We only assess pulse actually for 30 seconds. And then the remaining 30 seconds, we do respiratory rate. And that way they don't really know. So use whichever pattern works best for you, whichever technique works best for you. But that's just, two of the recommended techniques for assessing respiratory rate. Now, pulse oximetry is a way for us to assess respiration. Again, ventilation, respiration are a little bit different. Ventilation is, movement of air in and out of the lungs. It has nothing really to do with gas exchange. Respiration, that's the gas exchange process. So the most accurate way of assessing this would be look at arterial blood oxygen saturation of hemoglobin. So how much is hemoglobin, or how much is hemoglobin saturated with oxygen? And normally, to gather that, we would do an ABG, an arterial line. That's not something PTs do, and most people, you don't need to do that for everyone. So the way we can indirectly assess that by using pulse oximetry, which uses an infrared light that penetrates the nail beds or the fingers or the earlobe here. You've seen it even forehead sensors. And then this infrared light, the way it's reflected or transmitted through to the other side of the other sensor, will give us an indirect measurement of how well someone's blood is saturated, or hemoglobin is saturated with oxygen. Normal ranges, that should be about 95 to 100%. So again, if we're at sea level, that should be pretty close to 100, 95 to 100. And typically we don't refer, the threshold for referrals, anyone who falls below 90% for pulse oximetry. Now, there are some situations where you might have a lower threshold than normal. Someone who has a history of chronic lung disease or something of that nature may have a slightly lower threshold, and that depends on the patient, and they're usually aware of this. So just be mindful of that. And there is some degree of error, about a plus or minus 2%, especially when the true SaO2 is very, very low. So generally, you just got to be kind of mindful of that. Just caught a little bit of an error. This should be here, not there. Now, there are some factors that do impair accuracy. So anything that's going to impact the ability for that infrared light to transfer through the probe or through the skin is going to impact the quality of the signal. So if you have a lot of light around the probe or shining on it, that's going to impact the ability for the sensor to detect the infrared light. The thickness of your nails, if you're using a nail probe. So again, like if you have really thick nails, it's going to make it harder for that light to pass through. If you have darker skin, if you have a low perfusion state, or if you're very hypoxemic, the accuracy is just not there. It's just not super accurate when the values are very, very low. So just be mindful of that. Motion artifacts. So if you're moving your arm around a lot, like the signal might not be super accurate. So quite often people fall victim to this when they're assessing patients during exercise, that they get really concerned if, like the values are super low. Well, if you're assessing it during exercise, it might not be giving you an accurate reading. So you got to make sure the arm or whatever limb you're assessing is stable. That's why using maybe an ear probe might be better during movement. And if you're really concerned, quite often these devices will have a little waveform that you look at that lets you know, is this assessing, is the signal that you're getting accurate? Because if the waveform is not present or irregular on the monitor, that would indicate that it's inaccurate. And then obviously anemia and other conditions too. So that's pulse oximetry. So that's a quick and easy way for us to assess, again, respiration, which is slightly different than ventilation. And you'll see this in most outpatient clinics too. So that's our assessing the respiratory system overall. And next we'll start moving into pulse palpation. So let's have you guys practice that on your own, and then we'll see you for the next remaining parts of this lecture.